Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athlete trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have an education episode that's going back to the upper extremity. I feel like we don't have a lot of upper extremity education episodes. We are going to be talking about thoracic outlet syndrome.
Look at that. It's even before baseball, softball season.
We're getting everyone ready for fall ball.
I mean, water polo.
Yeah, and swim, which would be what water polo. But yeah, volleyball. Hold on.
You got some upper extremity sports in the fall.
Yeah, I do. Hey, that's why I felt inspired. Hey, let's start talking about the arms.
So this is a CEU episode. Thank you so much to Athletic Training Chat and Clinically Pressed. If you guys are interested in claiming this CEU, the link is in our show notes. You can also go to our Instagram at AT Corner Podcast. We have the pin to the top. We have a tutorial of how to get your CEUs. And make sure you check out the rest because some of them are free, including probably this one.
Yes.
So what are we talking about, Randy?
So we are going to be talking about just an overview of thoracic outlet syndrome. So it wouldn't be a pathologies episode unless we talked about the anatomy that's relevant to the thoracic outlet. Then we'll discuss the evaluation process for a patient that you suspect has thoracic outlet syndrome. And then we'll discuss specific therapeutic interventions for that said patient with thoracic outlet syndrome.
Let's do it. Start with the anatomy.
Yeah, so get jumping on into the anatomy. All right, so the thoracic outlet is basically that space between the lower neck and then the axilla, right, or your armpit. All right, so it's kind of defined with the clavicle being the anterior structure, the first rib being the posterior structure, and then the pec minor is kind of like that, or the insertion of the pec minor is that lateral portion of it, right? So we're talking about that little box right in there.
Triangle?
Giant triangle, yeah, you're right. Yeah, that'd be a giant triangle. In this space, right, we have the brachial plexus that runs through there, the subclavian vein, and then the subclavian artery all kind of run through that space. All right, now there are three kind of spaces that can cause some issues for those structures that kind of run through there. All right, the first one could be the inner scalene triangle. More geometry. People probably didn't think we were having geometry in this.
Geometry, anatomy, I feel like we're going back to school.
All right, so the inner scalene triangle is made up of the anterior scalene on the anterior side, the middle scalene on the posterior side, and then that first rib is the inferior aspect of the triangle. All right, the next space that could be a little bit of a bugaboo is the costoclavicular space. All right, so on the anterior side of this little space, you have the clavicle, then you have the subclavius muscle, and also the costocoracoid ligament. On the posterior side, again, that first rib. First rib's kind of being a problem.
I feel like I've heard first rib too many times.
Already.
Yeah.
A lot of first rib.
First rib is a problem child.
Then the anterior scalene, and then the middle scalene. All right, and then on the lateral side, you kind of have the scapula kind of poking its head around.
I feel like the thing that really sucks about the first rib is it's the thing you can't... I mean, you can do a mobilization on it technically.
It's so hard.
But it's so hard to get to.
Yeah. Just
because of where it is and just the depth that it is. And really, if it really is first rib, this is a surgical thing.
Yeah. Which will kind of be brushed on a little bit later, but yeah. I mean, there's really not much you're going to do to that first rib, like you said. Like
you just hope that it's literally anything else that we're talking about right now.
And then the final bugaboo spot is going to be that retropectoralis minor space. Right? So this is the space that's posterior to the pec minor on the anterior aspect, or it'll be anterior to ribs 2 through 4, and then it's just inferior to the coracoid process. Now that we have just kind of our bearings of what the hell the thoracic outlet even is, now we have to explain what the syndrome is, right? We know thoracic outlet, now let's talk about the syndrome. All right, so basically what thoracic outlet syndrome is just a compression of the brachial plexus, subclavian vein, and or the subclavian artery within any of those spots within the thoracic outlet.
There's a lot of spots that can be compromised.
Yes, there's a lot of problem children that could be involved in this game. All right. So thoracic outlet syndrome is kind of divided into 3 types, and really the types are based on what structure's being compressed or which one's causing or what's being damaged, essentially.
Right.
All right. So you have neurogenic TOS, which is the compression of the brachial plexus. Right. So this is going to be your most common case. Like most of your thoracic outlet, when you think about it, is going to be a brachial plexus. So this is around 95% of cases, right? And essentially what happens is the compression against like those nerves leads to scarring around the nerve, which, as we all know, nerves don't like compression
or stretch.
They don't like compression or stretch. And then you put like a bunch of scar tissue around them, which now they don't move very well, which means they're being compressed more or more tension on them. Again, nerves hate it.
Yep. Sounds like a nightmare.
Yeah, sounds like a recipe for disaster.
Yep, there you go.
All right, the next type is your venous thoracic outlet syndrome. This is the actual compression of the subclavian vein. This is going to account for maybe about 3% of cases. It can also be known as Paget-Schroeder syndrome, right? Because it can create a clot within there and then create some of the symptoms similar to thoracic outlet syndrome. So sometimes that's been kind of described as the same. Essentially what happens is there's compression of the subclavian vein. And again, same thing, scarring around the vein and within the walls of the vein. And this scarring creates a blockage in blood and blood returning, from the arm. All right, so again, that could be a bit of a problem. Right? Blood doesn't like to be blocked.
No.
It's not a big fan.
No.
All right, and then finally your arterial TOS, which is the compression of the subclavian artery. This one tends to be the more rare one.
That's probably a good thing.
Yeah, probably a good thing. But what's interesting is, kind of getting ahead of ourselves with the evaluation, is a lot of our evaluation stuff is on the distal pulse.
You're right.
Which is very interesting. All right, so this will account for about 1% of cases. And what was actually interesting, one article I was reading is, like those tests, like you could have a diminished pulse, but that may not actually be like arterial, like the artery being compressed.
Is it because the 1% is actually a full compression versus...
Oh, that's a good question.
Versus just a partial compression when something else is actually being fully compressed?
I think it would actually be fully defined as that kind of full compression, kind of like it's full, like it's actually being that artery is actually being compressed as opposed to something else down the line.
Right, because as we learned, there is a lot of potential problem children in the thoracic outlet.
Yes.
And if that space is compressed, then I assume the subclavian artery is going to be compressed to some extent. If the subclavian vein and or the brachial plexus is getting compressed.
Yeah, like this
would be very confusing if there's so much compression in one area and the artery's not getting. Yeah,
for sure. And I think that's the interesting thing about it is like these spaces are really small.
Exactly. That's right.
I highly doubt just one is and not the others. Right. So yeah, that's a great point. So essentially what happens is the compression on the artery leads to an aneurysm in the arterial wall that's kind of distal from the blockage, right? Because basically part of the hose is getting pinched off. So now there's like a reaction of dilating the other end of the hose to try and let as much of that blood flow through, and then you get an aneurysm. So that's kind of like how they're kind of broken down. The nice thing is, as we jump into the evaluation, there are some differences between the 3 types that hopefully will kind of key in, like, this is the structure that's causing the problem.
Right.
Like you said, you brought up a good point. Like, I'm sure all 3 are being compressed in some way, shape, or form.
Right. But which one's there's like a primary.
Yeah, like which one's the one that's causing the actual issues that we see.
Okay, so what are some things that people might say that kind of clue you in to evaluate for this?
For sure. So, in a neurogenic case, right, they're obviously going to have pain in their shoulder or arm, right? They'll have paresthesia and possibly complaints of weakness. And this weakness or pain could radiate from the neck, shoulder, and down the arm, right? There's some stuff that even can go into the scapula. What's interesting, though, because it is the whole, like, plexus, that's being compressed. It doesn't really follow a particular dermatome, which is kind of nice. That kind of gives you something else to narrow down if like someone's having like dermatome pain. Like, okay, they may not have thoracic outlet.
Right.
All right. So that kind of helps. What was also interesting is that they could complain of night pain as well. So they could have pain at rest, like in the evening and stuff, and probably like laying on that side.
Like nerve night pain?
Yes.
It's neurogenic? Okay.
Yeah. All right. So again, and possibly like, laying on that side. Oh, ow. Pain.
Compression.
All right. The interesting thing as we start talking about the vascular types is what really sets them apart is obviously the vascular component of it.
Mm-hmm.
All right. So for venous TOS, right, in addition to possibly having some pain, right, they may have arm swelling, right, or the cyanosis as well, right, or they may just complain of just their arm feels heavy, right. They could also present with engorged superficial veins of the arm, neck, or even at the chest. When it's kind of like in the chest, it's referred to as Urschel sign, which is just dilated collateral veins in the chest, right? Like just almost looks like, I don't want to say varicose veins, but it almost
that's what I was kind of thinking.
It almost kind of looks like that.
Mm-hmm.
Like if you see weird veins, just that's probably not normal.
Right.
I'd probably throw that in there. So that's what I thought was very interesting. And the reason you get that is because there is a blockage of the vein returning. Your body doesn't like it. So the body's like, hey, I can fix this. I can get around this, and starts going into like some collateral veins to still maintain the return. So they get a little like engorged with more blood than what they're probably used to.
It's like when the freeway is blocked and then everyone's like, I'm going to take side streets.
Yeah.
And then the side streets get all
blocked. And the next thing you know, you're called Urschel sign.
Yeah, there you go.
There you go. All right. And then going into arterial now, right? Again, pain is going to be something, but you could have pallor, paresthesia, and even coldness in the extremity, right? You're not getting as much blood flow in there, so the warmth is starting to go away.
The color, the warmth, the feeling.
Yeah. They can also present with ischemia in the hands, which it was one of the
oxygen.
Yeah. One of the articles actually had a pretty good picture, and it's almost like it's really subtle, but it had a picture of like just black discoloration at like fingertips. It was very interesting. It was kind of cool.
Almost like frostbite, like
almost how I look at it is like almost, like in a plantar wart, you have that like dark spot. Mm-hmm. It almost looked like multiples of those at the fingertips that were super close together. Yeah, it was quite interesting. It was really cool. Another thing that I thought was, again, kind of useful going into your evaluation is at least a difference in systolic blood pressure of greater than or equal to 20 millimeters of mercury compared like between arms. So if you took blood pressure on one, the pathological side would have a difference in blood pressure by greater than 20 millimeters of mercury. So I thought that was interesting. It was like something that can actually like you can use to help kind of narrow in.
So this is actually really interesting when you talk about just taking someone's blood pressure and not knowing that they have thoracic outlet syndrome, because now it's like, should I take it on both sides if they're having shoulder pain?
Yeah.
And I'm suspecting TOS, because will this actually alter my blood pressure readings?
Isn't that crazy? Yay. Yay. Way to make physicals more fun now. The difference is greater than or equal to 20 millimeters of mercury, but I think the side that's pathological would be less because there's less blood flow going in, so less pressure being exerted.
Yeah, that makes sense.
So I think that would be the lower side.
Right. That would make sense, since the arterial vein, the arterial vein, that makes no sense. The artery is being compressed.
Yeah, for sure.
Actually, speaking of, before I forget, the references that Randy used for this are on our website. So if you're interested in reading as much as Randy does, or if you're interested in just checking out somewhere where it says something about systolic BP or any of those things, you guys can check
pictures.
Those. Or the pictures. That's actually what made me think of it. Right.
Yeah, one article did have some pretty cool pictures.
Check them out.
And another one, again, because of like the lack of fresh blood flow, right? The arm fatigue, right? Their arm can feel fatigued sooner, right? That one's kind of crosses over to kind of neurogenic and maybe venous, but that one kind of tended to pop up more with arterial. So yeah, anytime you're hearing arm fatigue, that's probably not a good thing for actually most shoulder issues.
Yeah. I mean, anytime you're talking about arm fatigue, you're like someone's like, oh, my arm feels like heavy.
Yeah.
You're thinking some sort of blood flow.
Yeah, for sure. Oh, yeah.
That oxygen's not getting there.
Yeah, either oxygen. Yeah, somehow oxygen's not getting there or getting out of there.
Right.
All right. So that's what they may kind of complain of, or some things you could see. But of course, everyone's excited to do special tests. And I feel like for the most part, like ATs are pretty familiar with most of the tests that we know for like TOS. What I did think was interesting, though, is none of the articles talked about Allen's test.
Why?
I don't know.
Allen is like my number one.
I love Allen's
That's the
test.
first one I
feel so bad now.
Right.
I'm like, great. I mean, I didn't specifically go look for it, but literally all the reviews, everything, nothing's referred to Allen's test.
Poor Allen.
I know, it made me sad. That's a fun one. Snobby waiter.
Oh, we learned as you hold the boombox you're holding is too loud, so you look away.
That one's pretty good.
Yeah,
we always knew it as just snobby waiter.
That's funny too.
Yeah, I mean boomboxes are pretty cool though.
I was Allen's test for our class Halloween one year.
I remember that. It was a pretty cool costume. Basically, how the rating of these tests is in general, they were all pretty sensitive. Right, but they weren't very specific. So that means like if they're negative, more than likely it's not TOS. That's the problem. But if they're positive,
could be
almost anything.
Right.
All right. So the first one is again a pretty common one that I think everyone knows at this point is Adson's. It had a sensitivity of 79 to 92%. This one was probably the best one in terms of specificity, and it actually was like 76%.
So Adson's, for a review, is where you have your arm down by kind of like just like 30 degrees?
Yeah, I was actually thinking that way.
30 degrees out,
that, yeah.
And you're looking towards the hand that's out.
Yes.
And the way I remember it is like if you're holding the hand of your son, like you're looking at your son.
Yeah. And basically, right, a positive would be a diminished pulse or reproduction of the symptoms. The next test would be probably everyone's favorite if you know it. It's a fun one. Ruse test.
The one that everyone makes fun of.
Yes, the one that everyone makes fun of because it almost looks like you're, I don't want to say chicken dance, right? Oh, no, chicken dance. Yeah, you do this in the chicken dance.
Oh, yeah, you do that in the
You do the hand. Yeah, the chicken dance one. Ruse test is also known as elevated arm stress test.
I think that the reason why people make fun of it is because you have to do it for like 3 minutes or 2 minutes or something.
Yeah, 3 minutes.
3 minutes.
So you're just having their opening arms up, opening and closing hands.
Although honestly, I have done this one time before with someone who had thoracic outlet syndrome, and it didn't take 3 minutes. Was it 3 minutes? I already forgot.
Ooh,
3 minutes?
We're going to talk about up to 3 minutes.
See, it literally already.
Okay.
It took about like between 10 and 20 seconds.
Okay, we're gonna go into that. So, as much as it's fun to make fun of this test, right? Sensitivity again, pretty good, 84 to 94%. Specificity alone is only about 30%. But what was interesting was,
wow, that's really interesting.
Yeah, but when it's
specificity is super low.
Yeah, but when it's paired with Adson's, the specificity jumps to 82%.
Spin. So
If
roll
both,
it in.
Yeah.
So if you have two tests that are positive, you can be a little bit more confident.
That
82%. Okay, that makes sense though.
Yeah, it does.
But like if you have two confirmatory, two positives, continue a positive.
Yes, for sure.
Yeah.
Again, going back to math.
Just makes sense.
It just makes sense. The math is mathing.
2 + 2 equals
4.
Positive.
Positive 4.
Yeah, positive 4.
All right, so in neurogenic cases, so this is why it's interesting that you brought this up, symptoms can present within 20 to 30 seconds. So you don't even have to necessarily go the full 3 minutes. And it can present kind of
It was a neurologic
within
case,
a minute.
Neurogenic.
Yeah, see? And it popped up really quick.
Mm-hmm.
All right. And it can pop up. You don't necessarily have to go the full 3 for neurogenic. It'll pump up pretty quick.
I want to say this was like 5 years ago, but I'm pretty sure I was working with someone who was sitting at their computer desk, and I want to say they had reached up to they were like, every single time I reach up to grab something out of my cabinet above my desk, like when I'm seated, like my arm feels funny. I think that's what they said.
Ooh,
something
that's interesting.
about that.
Yeah.
And I was like,
That doesn't sound good.
I feel like that really recreates Allen's test.
Yeah, it does. You're right.
So then I did Allen's test and it was positive, and then I did Rue's test and it was very, very quickly positive. I was like, I think you have thoracic outlet syndrome.
For sure. Keeping with the trend with the neurogenic part, we have upper limb tension test, which again, sensitivity of 72 to 97%. All right,
pretty good.
So upper limb tension test, at least because I know there's like 3 different ones that you could do. This one was basically like arms in abduction.
To 90.
What? Yeah, to like 90.
To 90.
And then wrist extension, and then lateral head tilt away from the side that you think is the injured side. All right, so basically just stretching the nerve in all that way. All right, so again, reproduction of the symptoms would be a positive, and then a relief of the symptoms by putting that arm or that wrist in wrist flexion should.
So basically, if you do the upper limb tension test and they have symptoms, it doesn't necessarily mean this thoracic outlet syndrome.
Yeah, correct.
However,
because the specificity is awful, it's 11 to 33%.
Right. But if you do that and they don't have symptoms, then you could pretty much say they don't have thoracic outlet syndrome.
Yeah, because that's going to be 72 to 97% sensitivity. So yeah, you have, if it's negative, you have a good shot of saying like, okay, it's probably not thoracic outlet.
Right. If they have thoracic outlet, it's probably going to be positive. But you can't say that if it's positive, it's thoracic outlet. It's like if a square's a rectangle, but not all rectangles are squares.
Yes. Yeah, I think I'm picking up what you're putting down. I got you. The next one that I brought up, because like there were like a good chunk of tests that they talked about, but at the end of the day, the theme was the same, and we could just bore you by describing tests that we probably have never heard of. But this next one I thought was kind of something different, something kind of like I know I haven't seen it before. Is the Syriax release. All right, so what this is, it's kind of targeting neurogenic kind of pain. And
this is an evaluation technique?
Yes.
Okay.
And what it is, right, especially if they start complaining of night pain, this is kind of indicated for it. Basically, the patient's going to just kind of cross their arms, all right? The clinician will go behind the patient, grab the elbows, and basically lift up to raise the shoulders. This position can be held up to 3 minutes. And basically, the positive is...
Like the clinician is holding them up for 3 minutes?
Yeah.
Oh.
Up to 3 minutes.
Okay.
So the positive for this test would be pain relief, right? So their symptoms go away.
Oh.
Right, and then as soon as you let go, it like would come back. All right, so that's something interesting. I thought it was a little bit different
basically
than what we...
shortening the nerve.
Yeah, you're basically opening up the space. That's the idea of what it's trying to do. Again, something different. I know all of us have time to just sit there and lift up an athlete for 3 minutes, up to 3 minutes, I should say. Because I guess if it immediately relieves it, you can just be like, okay, cool, I'm done.
No, because then they're going to be like, no, please do that. That helped.
Keep doing it. Keep doing it. So yeah, there you go. There's some special tests that, there was one that kind of talked about, it wasn't military brace, because military brace is head extension. But there was one that was similar to where arms were extended, but this time head was flexed. All right, but again, it just followed the same theme. The sensitivity was was like pretty good, and specificity was down the pooper. So
just follows all. I mean, here's the thing: is most of your evaluations are going to come from history anyway.
90% of it, right there.
Special tests are just,
especially shoulder special tests.
Right. Oof, shoulder special tests.
They're just. Students know.
I went to a talk one time from a physician that basically said, you could do all the special tests you want for the shoulder, but we're going to do an MRI. Like,
that's right. I remember that one. That makes me feel good.
Yeah.
Let's just take the history then. Save some time.
It's mostly like you just have to figure out if it's a red flag that you need to send to get an MRI.
Well, yeah. Okay. Speaking of red flag stuff and imaging, let's talk about the treatment.
Let's do it.
So neurogenic tends to be pretty conservative, right? They tend to just say, let's hit this with some rehab, see what happens. And so again, anytime we're talking about compression of things, we're going to focus on opening that thoracic outlet up, right? Get that space nice and open. All right, so mobilizing first rib, loosening the scalenes, pec minor, right? Depending on which structure you kind of identify could be the bigger culprit, or maybe both of them are like spasmy, right? Might as well just work on them both.
Real quick, did anything that you were reading talk about, like, let's say if you are mobilizing this first rib, like it is pretty deep in there.
Yeah.
Did anything talk about reproduction of symptoms while you're doing the manual therapy or while you're doing mobilizations or anything like that?
Not necessarily like in the mobilization part, but palpating that area, like kind of Erb's point and like kind of like where the brachial plexus is, could be tender.
Because I mean, if the scalenes are the issue, for example, and you're working on the scalenes, like you're obviously adding pressure to an extent on these scalenes.
For sure. Yeah, it was just more talk about actually palpating the brachial plexus tissue, being a reproduction of symptoms. Another thing is mobilizing nerve tissue with glides. Right, if there's a lot of scarring around the nerve, right, because it's been compressed, there's going to be some damage. Right, getting the nerve to start to glide and kind of like smooth out the surrounding scar tissue.
Nerve glides are so underrated.
They are. Like, you're a big fan.
I'm a big fan.
Especially upper extremity glides.
Upper extremity glides.
You're a big nerve glider.
Well, when you have people get stingers all the time.
All the time, yeah. I feel you.
I feel like they're so useful also because like people walk around with their shoulders up and they're just like so stressed and tense, and most of the time people do have neurologic nerve tension,
for sure.
So I feel like it's just very applicable.
Yeah, you might as well target it. Might as well attack it. All right, then of course, anytime we're talking about strengthening rehab shoulder stuff, scap stabilizers.
It's like the core of the shoulder,
for sure. Get that bad boy involved, right? We by placing the scapula in a better position, right? We're opening spaces, right? Especially right around pec minor. Right, that retro pectoralis minor space can be open more by getting that scapula to actually be in a proper position, and then improving our motor control and overhead activities. Right, so now that we have a good position, make sure we maintain an optimal position throughout movement. Right, so definitely motor control, as we've talked about with every pathology. It's not just about strength; it's about actually being able to use that strength in a functional capacity. And then don't forget to look at the kinetic chain, right? Make sure our cervical motion's normal, right? If we have any deficits in that can cause issues through the brachial plexus and the muscles of the scapula. Same thing with thoracic motion, right? That could cause a big issue, right? If the conservative approach rehab fails and they kind of give it about 4 to 6 months, then surgery might be needed to help kind of open up that space. The return to play is quite extensive. You're looking about 10 to 12 months.
I've only known one person to do to do a surgical thoracic outlet for a first rib.
Okay.
But I don't think they returned to sport.
Yeah, interesting. Because surgery, at least for neurogenic, is fairly successful. Like if it does get to that point about people at least returning to the activity that they felt they were at before. But yeah, the procedure, there are a lot of different ways they could do it, right? Taking out first rib. Sometimes they like cut the scalene and try and like put it somewhere else.
Like replace the scalene.
Yeah. Same thing with pec minor. They'll try to do that too. Like it kind of depends what they kind of see is.
Pec minor release, like manual therapy, is
super fun.
Super uncomfortable.
Yes. Fun, uncomfortable. It kind of depends on the party.
Both. Hurts so good.
Yeah. And depending on how you get your fingers in there, it could hurt the clinician.
It's like that little J, like whoop.
For your vascular pathologies, these are going to tend to be treated pretty aggressively, which I thought was interesting. Yeah. Like they jump to surgery pretty quickly.
I think you talk about anything vascular.
Yeah. Yeah, for sure.
Especially when you're talking about aneurysms and blockages.
Well, when you have an athlete come in like, hey, why is my arm partially blue? That could be mildly concerning. We need to fix that.
Right.
All right, so surgery will be indicated to kind of relieve the decompression. In a venous TOS, they'll also pair in anticoagulants in conjunction with surgery to decompress the area. Okay. Right. The idea is they're trying to reduce another blockage from kind of forming.
Right.
You know, there was some older stuff that they first tried just doing anticoagulants and see if that would work, but you're not fixing the compression part. So
right. As soon as you go back,
they didn't know necessarily, like there was no criteria to be like, oh, we can stop this now. Mm-hmm. So it's like you're on them forever, which isn't great for sport.
Right.
So it's kind of like it's better to have the decompression surgery as well, because now you have a set criteria of, oh, we can stop the anticoagulants at this point. Mm-hmm. So that's kind of one difference in a venous TOS compared to like maybe arteries and stuff. Rehab post-surgery for these ones kind of follows the same principle. There's a larger focus on just getting mobility back, right, of the scalenes and the shoulder with maybe some light activity at first. And then once that wound kind of heals, like the actual incision and then the structures underneath, then you can start kind of going into some heavier stuff. So this kind of comes around like 4 months for around a return to play, 4 to 6 months, which I thought was interesting compared to like neurogenic. It seemed like such a long time, but I guess the surgery isn't as intense on the structures. I don't know. I thought it was very interesting.
I wonder if the neurogenic also has to do, like how long it takes also has to do with like
That's
the
fair.
Nerve scarring.
That's fair, yeah.
And how slow, like what is like 3 to 4 millimeters that nerves grow at a time.
Oh yeah, for sure. Yeah, it could be that. Yeah, that's a good point. But yeah, and it's kind of interesting, like just the procedures that they can do to kind of identify what kind of TOS, because there's some stuff about injections that could be used therapeutically, like using Botox to help relax the scalene muscle. Mm-hmm. And if that helps with symptoms, that kind of confirms that muscle being the problem. Mm-hmm. Anesthetics can be used to kind of confirm TOS. So yeah, I thought it was very interesting. I think TOS is something that, again, I feel like you don't see that often, but when you see it, like, oh, you see it.
Yeah, right.
Like, it's pretty noticeable. I thought one thing was very interesting. Like, I'm trying to remember when we talked about it in school, and I feel like it was just like, hey, this is TOS. And by the way, neurogenic's the most common, but all our tests are looking at blood flow.
Right.
But I feel like we never talked about how, like, if you have someone with a vascular TOS, like, that needs to be referred ASAP. Yeah. Like, that has to be like referred quickly. And I feel like that was never emphasized in school. At least when I was a student. I don't remember them being like, hey, refer this ASAP.
Right.
So I thought that was really nice reading and actually getting, like, I don't want to say the severity, but like the urgency behind a vascular TOS.
Like seeing how aggressively it is treated.
Yeah, for sure.
Versus like the neurogenic, which is going to be it's going to be conservative first anyway.
Yeah, let's try that rehab, see what happens.
Right. Mobilization, do what you can.
Yeah. And obviously there is activity modification within that time frame too, right? Mm-hmm. We're not just trying rehab and be like, hey, yeah, just keep stressing that nerve the same way, right?
Right.
Give it a chance to let the tissue heal. And they could pair that with anti-inflammatories as well. Again, this is a conversation with your doc about what they think is going to be the best course, especially for like a conservative neurogenic approach.
Right.
Yeah. There you go. There's TOS.
What's your action item?
If it's vascular, it needs to be seen ASAP.
That's a perfect action.
I think it's to emphasize, because again, I don't remember being like such an emphasis put on this, but after reading it, I'm like, oh my gosh, this is a big. I mean, I guess if you have like weird dark spots in your finger and like your limbs turning blue,
if you have some red flags, you should probably
you should probably get that looked at.
Again, if you guys are interested in this CEU, scroll down to the show notes. We have the link down there. We also have the link on to our website for references. If you're interested in a video telling you how to claim the CEU, go to our Instagram at AT Corner Podcast, where you can also submit stories for one of our other types of episodes. We do education, story, and interview episodes. We have story episodes, which I believe will be next week, maybe the week after. I don't know. I gotta look. We will be doing stories from athletic trainers all over the world talking about one topic. So you can submit your stories on our Instagram stories. We also have interview topics where we bring people on. Well, I think that's it on my end. You got anything else ready?
Nope. Thank you for helping us showcase athletic training behind the tape. Bye.